I'm really happy to see that a number of people have shown up for our session. It looks really exciting, and really excited to hear what our panel has to share today. As I was introduced in the plenary, my name is Neha Mankani. Some of you have spoken to me at some point in this role, and I'm the Southeast Asia Regional Coordinator for the campaign. So as you heard in the plenary, the PUSH campaign is a decade-long global movement, and it aims to accelerate progress in reducing maternal and neonatal mortality. And in the center of this campaign is this idea that gender equity and women's reproductive health and rights are so closely linked to the work of midwives. So just to share a bit about what I've been doing in terms of the stakeholder mapping, in my role in South and Southeast Asia, I've been working to connect with midwifery stakeholders in countries across the region. So this includes Pakistan, India, Bangladesh. We're also continuing to do a bit of work in Indonesia and Nepal. And what we're trying to do is to understand the midwifery landscape and see how we can work with target countries to best achieve these advocacy goals in the specific region that Leanne spoke about. So we've been conducting mapping in these countries specifically because, and these countries were spoken as mentioned, because there's so much exciting work around midwifery already being done there. This includes the nurse practitioners and midwifery work that just started up in India, and the frameworks for midwifery education and upgradation that are taking place in Pakistan and Bangladesh, and all the midwifery work being done in Indonesia and Nepal as well. Like, these are countries that stand out. So what we aim to do through our work with stakeholders is to understand how we can support them in amplifying the advocacy ask, whether that is connecting new and unexpected allies and donors, communication work, strengthening associations, working with midwives to amplify their voices, or whatever else the stakeholders identify our role to be. So it's actually been a very interesting process, because stakeholders that we've explored have ranged from midwifery associations to governments, to donors, to midwives. We've met with some educators. Obstetricians have actually been a really big part of our work as well. Some really wonderful gender organizations who are doing really exciting work around sexual and reproductive health and rights, photojournalists, independent entities who've experienced the work of midwives and want to support it. We've met disability rights activists calling for safe birth. And what brings all these people together is that they all have a joint goal, because they all see value in the work of midwives. And we really hope that we can work with all these stakeholders to meet our joint goals. On a personal level, this has been a really exciting process for me. As a midwife, I've been part of the maternal health landscape for so many years, and my colleagues and I have seen and experienced firsthand the challenges midwives face, as well as the wonderful ways in which entire communities can transform and thrive when they have access to well-supported midwives. So that brings me to our panel discussion today, which is bringing in stakeholders from the region who've been doing some really great work on maternal health and midwifery. And they'll be sharing their experiences and helping us further understand the value and contributions of midwives in each of their regions, as well as what barriers and gaps midwives continue to experience. And I'm sure as you listen in, you'll have questions for them. Please put them in the chat box. And as we finish the panel, we will get to question and answers. So without further ado, I'm going to introduce the panel, and then we will start our session. So first we have Dr. Parithija. She is an Indian midwife with a doctorate from Uppsala University in Sweden. And she's been exploring quality of childbirth care in Indian low resource setting from the perspectives of women and their care providers. And in her 17 years career, Jaya has worked for strengthening midwifery education and services across 17 Indian states through her research, advocacy, and intervention mapping. And she's currently engaged as one of the WHO consultants for implementing the 7-step action plan for strengthening quality midwifery education for UHC 2030. Then we have caller Jameel, an independent freelance documentary photographer, photojournalist, and filmmaker. Caller is based in Karachi, and her work covers diverse subjects ranging from climate change and health to agriculture and human rights all over Pakistan. And her forte lies in creating visually impactful, human-centric stories, which she has done for many international organizations, including Oxfam, MSF, USAID, ICRC, and others, as well as through personal projects that work towards positive change. And then we have Tamim Akhtar, a midwife based in Bangladesh. Tamim serves as the vice president of the Bangladesh Midwifery Society. Her clinical work was at the Upazila Health Complex in Mymensingh, where she worked as a midwife, and she's currently in Dhaka, furthering her studies in midwifery. And Tamim's focus has specifically been around midwives and family planning, including postpartum family planning, menstrual regulation, post-abortion care, and MVA. And we're really excited to hear from her. Mehreen Shahid is our fourth speaker. Mehreen Shahid is a development practitioner and founder of the NGO Safe Delivery, Safe Mother, and she's based in Pakistan as well. She provides essential, Safe Delivery, Safe Mother provides essential life-saving maternal and reproductive healthcare for rural communities. Mehreen has over 10 years of experience in health education, gender equality, social protection, public-private partnerships. And she's an alumna of the Global Health Core Fellowship and the Forbes Ignite Fellowship. She also advises governments and clients in Pakistan and internationally on health systems, public education, and private sector engagement. So as you can see, a really fabulous panel here. And I'm going to get started by focusing my first question to Paridhi. And Paridhi, I want to ask you that what is, I've been speaking to a lot of stakeholders in India, and I want to understand from your vast experience, what has been the role of midwifery in community building and health system strengthening in your experience? And how do you see this new program that's coming in? How do you see that contributing to maternal health in the region? So I'd love to hear from you on that. Thank you.
Yeah, so traditionally, I think history is our witness that the auxiliary nurse midwives and the nurse midwives in general in India, they have actually been the torch bearers of all national health programs in India, and they are mostly directed at women and children's health, and be it immunization, be it reproductive health improvement, be it care, say a skilled birth attendant. So all these services that have been offered by the government, the nurse midwives in a way have been at the grassroots level, ensuring that the public and the community know about them, and cajoling them and convincing them to come to the health facilities, because India has been a low resource setting for quite some decades now, and they have been the primary push to ensure that the women come to the institutions or healthcare facilities for childbirth. Rather than, each woman is attended by a healthcare provider at the home, simply because we have acute shortage of healthcare providers. Later in the last few years, Ashas have taken over that role from ANM of convincing the women, but we cannot deny that they have been the ones that the communities trust and believe, and who are actually the link between the community and the hospitals. I see NPM as a very strong nurse practitioners and midwifery course that the government has launched in a cascading manner, the training of this cadre since 2019, delayed because of COVID, but I see it as a step towards positive, because now we have actually the guidelines that will operationalize midwife-led care units in India for the very first time. Some states have already started it, opening the MLCUs and posting the newly trained NPMs in these facilities. And I think the word of mouth is really strong in favor of NPMs. Yeah.
So what do you think would be some barriers that that nurse practitioner midwives might experience as they start their work? And what do you think are some barriers and facilitators that you have seen in your work? I know you've done a lot of research on quality of care. You've done a lot of research on this. So what do you think are some barriers and facilitators specifically for this workforce?
So I'll start with the facilitators, which is the very strong commitment by all development partners and the government for ensuring that the NPM cadre is functionalized at the earliest. So that is one of the biggest, once the policy making people and the people who are having the influence in terms of funding and policy, if they are in the favor of a cadre, very strong forces will be needed to stop that from happening. So that thankfully is the case with us. We have a very strong Society of Midwives India that has been advocating for midwifery as an independent profession for almost 2 decades, 3 decades now. So those are the obvious facilitators. In terms of barriers, one key barrier that we identified through our very recent study, very recently published, I think in May, is that there is a sort of role confusion still, not in the minds of the NPMs, but in the minds of the other, traditional health team members. Exactly what is so special about the NPMs sometimes is not very obvious to the other members of the health team. There has been some grassroots level rivalry, as well as some very good heartwarming stories, where the teams have come together. But acceptance of the midwives or the NPMs into the health team as a member of the health team, I think that has been a challenge for many who are younger and maybe not in a very strong position to make an advocacy for themselves. And then the second has been, somehow, somewhere, the perception of the community that, midwives as an alternate to the obstetrician. It needs a very careful advocacy to ensure the alternate is not seen as the lesser alternate. It has to be promoted very carefully. And I think White Ribbon Alliance in India and SOMI, they have both done a wonderful job in ensuring that this kind of support is created for the new professionals.
Thank you. That's really helpful. It's so interesting to see that the barriers are so similar everywhere. I mean, even what you said about, a lot of these providers are very young and they're not able to, they don't have the mobility or the ability to advocate for themselves. And I don't know what the role of traditional birth attendants has been in India, but I know in Pakistan, especially when they compete with traditional birth attendants, it becomes even more difficult. So, there's obstetricians, there's traditional birth attendants, there's midwives. So it's very interesting to see how all of these carriers will work together. So thank you so much, Preeti. We'll come back to you with some questions. We'll go next to Kola. And Kola, the question that I would like to start you off with is that, I've seen some of your work. It's been really wonderful, really powerful work. And so as a photographer and photojournalist who has covered health challenges, especially around maternal health in Pakistan extensively, what did you find about the maternal health gaps in your work? And as someone who has now, you have access to these maternal health gaps and you've seen the work of midwives, how do you see the importance of midwives in public health solutions?
Hi, Neha, and thank you for having me here. As a photographer, my job is mainly to do case studies on the maternal health issues for a lot of these development organizations. So the most common case studies I've done for maternal child health has been malnutrition or lack of intervention and the early stages of the woman's birth, which led to a series of severe complications. And then she's rushed to the hospital and brought practically on her deathbed with ruptured uterus and advice that wasn't meant for her. Like, for example, abuse of oxytocin is very common in Pakistan, where they induce way before then the woman is ready to give birth. So these are the kind of case studies I've done, amongst others, like miscarriages, conceiving immediately after a miscarriage. So lack of awareness and education leads to these kind of problems. And then obviously when the children are born, the neonatal rate is, mortality rate is, what it is, children die very early deaths. And a lot of cases I've seen while at these various hospitals from across Pakistan and from Sindh to KPK, which is like south to north, pretty much the same issues. Giving the child green tea as soon as they're born because the mother is not producing milk is a very common story I've done. Giving herbal concoctions to a child as soon as he goes home on day 2, that leads to, his internal organs getting ruined, and then the doctors have to manage that. And stories like, a prolapsed limb coming out, and then the, baby has to, the mother has to travel for hours sometimes, because most of Pakistan where these is rural and proper medical care is not available for, like, they have to travel 10 hours at a time to get to help, and they haven't. These are preventable things, a lot of them, and I think these are the gaps that I've noticed. So obviously the importance of educated medical practitioners, even if they are in rural communities, this would be great if they're actually trained and somehow, live in the communities where these problems occur, so that it doesn't have to get that bad when they're brought to the hospital. And even when they, you see, there's tertiary hospitals, there are bigger hospitals, and then there are hospitals which are closer to their villages, which have untrained midwives as well. I don't really know how they're employed. Sometimes, I don't know, through fake degrees, or, that's also very common. And they're there and they're giving ill advice, wrong advice, making the situation worse. So by the time they get to a proper city hospital, it's already so bad. So yeah, these are the situations. And I think based on these stories, I can actually, in the chat, I'll share one story I did for MSF that covers a lot of the issues.
Would you like to share your screen and show us some of your work if you'd like to? Like that would be nice. Yep, you should be able to.
Can you see my screen?
Yes.
Okay. So for example, this story I did, this was Gulshan's 40-year-old lady's 10th baby. And it was in Balochistan. And this was the first time she was giving birth in a hospital. And she'd had several miscarriages in the past. And she was married at the age of 14. So you can see that child marriages are very common here. So that's another issue that comes up in maternal health. She was extremely weak and she'd miscarried a child less than a year ago and she'd conceived this one. So no gaps, birthing gaps, was very common. Her 22-year-old son had come to pick her up and take her home in a rickshaw. There, 25 people from the family were waiting. Half of them are her children. These are the grandmothers, and they were telling me that they're planning on piercing the baby's ears because, as you can see, it's common in Baloch tradition to have pierced ears. But what happens is that if you do that too quick, then the baby could get tetanus, and that's a common cause of neonatal death in Pakistan. It's underreported because families obviously don't tell. But it's usually done within the first 6 days of the girl child's birth. And these are the kind of herbal concoctions that they're given. They were showing me that they're going to have a ceremony in the next couple of days and they're going to feed the child this. It's part of their tradition. And the medical practitioner who was with me was trying to tell them that this is something that they should avoid and in the nicest way possible. But it's very hard to work against tradition in a lot of these communities. And that's one of the biggest challenges also that midwives face, convincing communities not to give up on 100-year-old traditions. So this was one. And the prolapse limb story, just to quickly go through that, the doctor had to take a very quick decision to not do a C-section because that's another challenge midwives face, is that C-sections are considered big operations. And essentially it means the woman is not going to be able to do house chores for a while. So it's not recommended, like husbands absolutely say no to it. So that's another challenge women face in Pakistan. Luckily, this child didn't have a fracture, so that was good. This was probably one of the most terrible stories where she, 26-year-old, very rural agency part of Pakistan, she couldn't get to help in time. She came with a ruptured, practically a ruptured uterus. The doctor or midwife, the community medical practitioner had given her 3 injections and 2 tablets and said she would be fine. The lady health worker kept trying to force her to deliver the baby with 2 drips. High dose of oxytocin and misoprostol tablets were to induce labor. Unfortunately, after a few days, the baby did pass away, and this is extremely common in Pakistan, where they reach the hospital after everything's been lost, and it's expensive. It costs them. So there's the mental health aspect as well, which I won't get into in detail right now. But maternal child health, the women have to face a lot in Pakistan, from mental health to malnutrition, because they come from very large families. So that is the picture. the importance is clear. Don't think I need to emphasize on that.
Thank you so much, Carla. That's really, your work is extremely powerful and extremely useful. And as a midwife, as someone who's just worked in the community, looking at these case studies, I can identify, 20 things that could have been done differently if there was a trained community midwife present in the area. It ranges from birth spacing to just getting antenatal care to health education to community mobilization. There's just nutritional interventions. There's just so many things, and it's just really I think the case studies that you shared just made it so clear what the role of a community midwife would have been, a trained community midwife in that area. And I know a lot of these women can't access care just because of cost and infrastructure, just those things. So thank you so much, and we'll come back to you with some more questions. And thank you so much for sharing.
Thank you.
And since we're talking about some field challenges in Pakistan, I'm going to move on to Marine. And Marine, your work at Safe Delivery, Safe Mother, I know has been very interesting, specifically around trainings and healthcare providers. And I think you've also done a lot of gender work. And so how do you see the contribution of skilled midwives to gender equity in Pakistan? And what do you, in your work, what do you think are the gaps that midwives experience? And, what are the gaps that they fill in the community, and what barriers do you see them experiencing?
All right. So hi, Neha. First of all, thank you for having me here. So the work that we specifically are doing is so community oriented and based in the field. And the trainings that we do engage with skilled birth attendants and community health workers. So a lot of the work that we've seen in these communities, especially in rural, remote and low resource communities, is that women do not have agency over their own bodies, right? So they're not the decision makers for themselves. So you'll have either the mother-in-law or the husband deciding. So what's very important that we've seen is, when we look into it from a gender equality lens, is how do we engage with these key decision makers along the process of maternal health care? So during antenatal care, whether it's at the time of delivery or beyond, depending on where exactly you capture these women. And I say this is because a lot of these women come for healthcare services when they're pregnant, when they have any issue. Otherwise, it's difficult to get hold of them. And there's not a lot of recognition or the importance of going to a birth facility or a primary healthcare facility. So I think what needs to be done is we need to think more innovatively. We need to think about how do we reach these women and in what capacity. So in many ways, for example, we teach counseling techniques. We teach them how to engage depending on the socioeconomic constraints and challenges that communities face. So for example, just to give a few examples, we don't only look at communities where women are not allowed to leave their houses. I've been in such culturally sensitive communities where a woman will not take a contraceptive device because the mosque imam has said that if you have a device in your body, your funeral rites can't be read according to Islam. And that's a huge thing to say in a community. So you can't go in that community and say, this is actually wrong. What you're saying, you're doing is you're misusing religion. That's not the approach. So you have to approach the issue very sensitively. Then we engage with community leaders, with mosque imams as well. We train birth attendants in terms of how to position themselves, how to create synergies with health workers. All of this approach creates more of a gendered lens, as opposed to assuming that a woman comes with her family to a healthcare facility, seeks the care and leaves. Oftentimes I say this a lot, value chain is probably not the right word to use for it, but I say when you see a woman in a village sitting at a primary healthcare facility, you should know that she has overcome tremendous amounts of socioeconomic challenges to sit there. So the non-clinical side of healthcare is more important, because coming and getting healthcare is the next step, right? But being able to reach, and we have about, I think if we look at statistics, over 60% of Pakistan's population is rural. If we look at remote areas, we have seen far-flung areas where healthcare facilities are not there. I speak for primary healthcare facilities, let alone hospitals. Punjab, being the most populous province of the country, has about 110 million population. We see over 3 million annual deliveries. We have about over 10,000 birth attendants mobilized. We have 100,000 health workers, one of the largest frontline health worker program in the world. You need to look at all of these, but you also need to look at how are you mobilizing them? How are you? So, there many times, there's another area I went where couples were observing parda, a veil from each other. So the woman came to the health facility. She had never seen a husband. Now, when I heard that story, I couldn't sleep for days. I was like, this is ridiculous. She said, I don't know what my husband looks like. I don't know his name. So we know that this woman came only once, speaking about a problem. Capturing her at that point is so important. She may or may not come back. So I think these techniques, engaging with the community, talking about the rights of a woman, giving her agency, even if she's not able to act on it, and enabling her to get that access. I think these are some of the elements that we work with in the community to get some kind of a gender equality basis. Obviously, we've got a long way to go, but that's exactly our starting point.
So when you met these, that's really interesting. Like the approach, and I'm curious about when so you met a lot of these. I know that the work you were doing with skilled birth attendants. So a lot of them were midwives and lady health visitors who are basically community midwives, right? So what did you see as some of the gaps that they experienced in care? Like, what were skills that they were missing, or, about salary, or what did they share with you, Marine?
So I can give you an example of a very recent project we did, and you'd be surprised when I went. We went to Multan, which is one of the largest districts in the south, and we were covering the entire district. So essentially, we work with the government. So we cover the entire district when we do. So we were teaching them on implants and IUDs, the use of IUDs. So we focused again on the postpartum side, because as I mentioned, that's where women are accessible and open to listening. The birth attendants did not know that the IUD device is the same when used at an interval stage and used postpartum. The only difference is in timing. So they thought the postpartum device was entirely different. They had never received trainings on this. It's a critical, cost-effective skill that needs to be told. So I think skills on that, use of misoprostol tablets is something we've struggled with. So overuse, how that's wrongly used for abortion, that's on that side. And then also these health visitors and community midwives do not feel respected and recognized, because they're the ones at the front line doing everything. They're the ones I speak for Pakistan, but they're doing dengue duties. They're doing polio rounds. We're struggling with polio. COVID came in. They're doing that as well. Essentially, they've been hired to provide MNCH facilities, but they don't get to that. So that happened. Then there was a shift after the 18th Amendment, which devolved a lot of the rights to the provinces, where a lot of these midwives and lady health visitors got moved to become permanent government employees. Now that improved the situation, but they're very, underpaid. So respect for the work that they do, recognition, lacking actual skills, and being taught to think from their mind. I think the fact that when I sit with them and they tell me bleak stories about, what happened at midnight, and I ask them basic questions, but they don't have the analytical skills, or they haven't been trained that way to think, to execute, and to deliver. And that by no means, I think, is their fault, right?
Yeah, that makes complete sense. Like, that's just some of the stuff that I've seen in my work as well with midwives, that a lot of it is just the gap in analytical skills, because they don't receive the kind of training that they need to be, effective community workers. And what you're saying about implants and IUCDs and long-term methods is so interesting, because that's such a big gap that we experience in Pakistan. Like, for our CPR to increase, like, long-term methods is something that all midwives should be effectively trained on. But that's great. Thank you so much. And we'll come back to you with some more questions. And since we're on the topic of family planning, we're going to now go towards Tamim and her work. And so, Tamim, when you talk about contraception and family planning, I think whenever we talk about South Asia, the first country that comes to mind is Bangladesh, because Bangladesh has been a country that we all look to learn from when it comes to the success of family planning programs. So what do you see as a midwife who's, even done clinical work, and now you're the vice president of the Bangladesh Midwifery Society? So what do you see as the role of midwives in family planning success in Bangladesh?
Thank you, Neha. I'm grateful for having me on this platform. This is Tamim Akhtar. I'm midwife from Bangladesh and vice president of Bangladesh Midwifery Society. I have been working for 5 years in midwifery sector, and I have seen the way that midwives contribute to not only the midwifery and midwifery services and maternal health situation in the country, but over the public health challenges as well. One demonstrated area of success in experience is postpartum family planning and post-abortion care menstrual regulation as well. According to Family Planning 2030, Bangladesh has a current contraceptive prevalence rate of close to 46 46% with a net need of almost 74%. Midwives can be the key to the success of Bangladesh family planning program. In Bangladesh, family planning remains one of the top priorities of the health sector as a path toward achieving the Sustainable Development Goal. Bangladesh has prioritized implementing the National Action Plan for Postpartum Family Planning and has strengthened its efforts to increase trained service providers, including deploying midwives and to all sub-district hospitals. When I was engaged in my working place, I saw many instances of my role as a midwife and how it contributed to safe outcomes for women and the ability of women to exercise their own reproductive rights. Midwives are able to establish a specific kind of relationship with women because their first contact in communities and health centers and are able to provide effective counseling, practice restful care, and understand community dynamics and barriers. I would like to share a story how I convinced a woman and her family to get an IUD service. When I worked in an NGO but posted in a sub-district hospital, in that time only I was a midwife worked in that hospital. I did only antenatal checkup and normal delivery. In the meantime, I got a chance to do a comprehensive training on that. So I got the training on menstrual regulation, post-abortion care, and MFA training. So I got back and also I got the training on postpartum family planning. So I got back as a trained person on postpartum family planning. One day, one day I was in a NC corner for checkup pregnant women. A pregnant mother came to me for her NC visit, and she was pregnant for 5th time. And I completed all the NC checkup and with her permission, I talked about the postpartum family planning, which is an immediate family planning, postpartum family planning. It is IUD service. But the women told me that it is not her decision. You need to take permission from her husband and also from her family members like mothers-in-law. And in next 2 visits, I counseled her husband and also her mother-in-law and also her for taking the PPFP. And at last, they agreed for IUD service, and they told about a condition that if it is possible to come in hospital for normal delivery and everything would be fine, after that they will take the IUD service. And fortunately, her delivery conducted by me in that hospital, and everything was fine of the pregnant woman, and her baby was fine, and she was fine. And after that, she was agreed for IUD service. And finally, I convinced her to get the IUD service. As mentioned above, another important aspect for public health and that midwives are engaged in is menstrual regulation and post-abortion care. It is also the part of family planning because every postpartum period, the pregnant women comes more and become more unwanted pregnant, and also need they comes to for MR, menstrual regulation, and also for post-abortion care. And the menstrual regulation and post-abortion care, this as I mentioned, midwives need training. This training on MRPAC and manual vacuum aspiration enables women's right to choose is also the difference between life and death for so many women. In a study conducted by Goodman Institute, it is estimated that in 1 year there are 384,000 women who experience complications of unsafe abortion. Training for midwives and including in PPFP services and also the MRPAC MVA services can be the success rate in family planning sector, because midwives are really engaged with pregnant women from the first early period of pregnancy, and 2 or 3, 4 times pregnant mother come to midwives, and they counsel them very closely, and they can counsel them for immediate postpartum family planning. And by this family planning rate come to successful by midwives contribution. Thank you.
Thank you so much, Tamim. Thank you. I think it's just your stories are just testament to what a trained midwife can do. And, you know, the fact that you can provide, you were at this facility and you were able to convince a woman to get a postpartum IUCD, you were engaged in post-abortion care work, is just, your work is really powerful and really needed. And thank you so much. And as I move on to a few more questions from the panel, I actually would like to ask you the first question, Tamim, because we're talking about public health work that midwives do. And I think in one of our conversations, you had mentioned to me that there was some other humanitarian work in Bangladesh that midwives were engaged in as well. And could you just share in a few sentences what the role of midwives in humanitarian work has been in your experience?
Yes, sure. A very big contribution of midwives in Bangladesh in the humanitarian sector in the Cox's Bazar refugee camp. The role of midwives here has been really instrumental, because it is a very challenging site, yet they establish themselves and become trusted providers in a community that has been affected by so heavily by violence and trauma. The needs of women living in emergencies and protracted emergencies are very unique and specific. Midwives provide much needed maternal health care, package of reproductive health in crisis situation, but also provide community awareness on gender-based violence, clinical management of rape and sexual violence, and health education in the communities and adolescent health care, etc. And also midwives are doing with all the public service, and also the mentioned job, they also do the NCPNC and normal delivery services in the humanitarian area.
Okay.
Thank you.
That's really great to see the work of midwives in Cox's Bazar, because that cannot be an easy environment to work in. So it's really great to hear that they're there and they're able to do this. Sorry, I muted myself by mistake. So we don't have a lot of time, but I have just a few other questions. Kala, I have one more question from you, that, you know, you've used photography to share women's stories, but do you know of ways that we can help midwives advocate for their own rights in our regions, you know, in terms of, do you think that using arts as an approach is useful in that way? So what are your thoughts on that as a photographer and a photojournalist?
Yeah, I think, Instagram is honestly the best way to reach people and advocate for anything these days, social media. Visually, it would be great if, I know with privacy is a huge thing in documenting maternal stories specifically, but if midwives were to share their experiences, everyday experiences, with just, in one photograph, about the problems, I think that could spread a lot of awareness, because dialogue and discussion tends to happen more fluidly and organically on social media and with one visual at least, so even if you've seen my work, it's very challenging for me to photograph maternal stories. So it's always the hand or the side of a woman, especially from very conservative parts of the North. So if midwives could, and there are lots of stories, like when I'm sitting in the ward with the midwives, they're constantly telling me stories which I think are very, very powerful. And if they can, even if it's anonymously done, have like some kind of channel to let this out in, that would be good. Maybe an Instagram page.
Yeah, I think that would definitely work. I think Kola had also done a little bit of work at some point a few years ago while I was in midwifery school. She had done some work through her. She was doing something around Humans of Karachi at that time, and she had showcased some stories of midwives. And I remember those stories were very powerful, and it just really changes how people understand.
Well. They did really well, like in terms of virality, because people were really interested in the stories and the work. And even these stories that I've shared, they're on my website and the official pages of the organizations I've done it for, but I've shared it on my own Instagram as well. And they've always garnered a lot of interest, a lot of comments, and a lot of shares. So people are interested, and this is the way to get it out there to create the dialogue.
Okay, thank you, Kola. So I had another question for Paridhi, if you'd like to answer that, Paridhi. So I know that some of the evidence that has been coming out of India has been really strong, and I know that evidence around midwifery work it doesn't exist so much in a lot of parts of the region, but in India a lot of really good work has been coming out. So would you share the findings of some of the evidence that you've generated on competencies, barriers, and facilitators? Because I saw that you had done a bit of research on that.
Yeah, so I already spoke on a few of the points that we have found out, that the facilitators have been basically, the very strong and coordinated effort by all the development partners, and the rising sensitivity, I think, in the community from the few NPNs that we have. I should make a special mention to Fernandez Foundation that has piloted the first midwifery program for their own staff first, and then it became a model for the government in Telangana state, and then from there it took hold across India.
The work of Fernandez Foundation has been great, and especially because it's got obstetricians at the helm of it, which is even more amazing that we have these amazing obstetricians advocating for midwives.
Yes, obviously, and it's very good to have strong midwives, but what Fernandez has managed to do is to show that obstetricians are not really the enemy, So we need not, as the new cadre, need not be so defensive or, consider all obstetricians as our competition. So they are quite willing. I think all the societies of obstetricians in India, or associations of the Foxy and everything, they are actually quite they are not really in opposition. What I mean to say is that they are quite willing to work alongside the midwives and see how everything goes. So I see that as a very big positive side. And of course, the one thing that I would also like to make special mention of is that the government has taken a very strong interest in the whole drive. So all the partners, the task division between the partners has also been very, realistic, and so that no overlap happens between two partners' work, so that we are optimizing all the resources available in the best possible way. And that has been, I think, a very good move. Other strong support is SOMI itself. I'm so sorry, it's 9 o'clock in India, and I have a young baby, 1 year old. So yeah, so it has been, a lot of support and growing awareness created by SOMI and other organizations that are actually supporting midwifery in India. The key barriers, if I can come to, have been One is the visibility and the role identity. And the second has been, to some extent, I feel philosophically, most of the nurse midwifery cadre in India is more, we are trained in a way that we are nurses first and midwifery is part of nursing. So I think that kind of awareness that midwifery is an independent profession in itself, that will grow slowly with the NPMs getting more empowered. Another challenge has been, if for some reason we do not have a very strong person sitting in the central position in the state governments, that is actually very sensitive to the challenges faced by midwives or the NPMs, then that can be a challenge, because you are posting a very new cadre with a lot of expectations, and only time will tell how they take it, in their stride, or exactly what do they do. So I think the whole course, the whole NPM, this thing is such a new thing that only time will tell how it proceeds. But right now, I think everything is in place for a very strong move, basically, in India.
Yeah, we're really excited to see how things go with the program, and really sorry, thank you so much for being here. And I'm sorry to keep you from your son at bedtime, but thank you for speaking with us anyway.
Yeah, my pleasure.
So before we close, we take some questions from the audience. I know there's some key stakeholders. I've been looking at the comment box, chat box, and I see that we have some people who from Bangladesh, and we have midwifery educators and women from White Ribbon Alliance. So if anyone would like to ask anything, or even just give their analysis of midwifery, we're happy to hear it before we close.
Hi, I've got my hand up. Is it all right if I say something?
Yes, please.
I'm Marianne Lumsden. I'm from FIGO, which, as many of you all know, is a society of obstetricians and gynecologists. And I was very heartened to hear support for obstetricians and midwives working together, because we're so much stronger together. And I think a lot of this sort of antagonism actually is not reality. And having practiced obstetrics for many, many, many years and seen it overseas, it is most important that we do try and get the positive across, because it's far better for women. I personally have always been extremely supportive of midwives, because they see a bulk of the women, there's no doubt, as you've been saying. It's been a very good session. Thank you, and some very interesting points to take forward into the future.
Thank you so much. It's really, even for me, it's really heartening to see that obstetricians and midwives are working together, and really great to hear from you as well. And also to see that some of the work in Bangladesh, some of the work in India, lots of the work in India and Pakistan is doing well because obstetricians and midwives are working together. And that's, I think that's the basis of it, that competition does not need to exist. They just need to work in collaboration for this model to work. So thank you so much, Marianne. I think someone wanted to... Sangeeta, did you want to say something? I think Joy said that you might like to speak, or Joy, if you had any comments.
Thank you. I did see Sangeeta online. I think she may have dropped off. Hello, everyone. I'm Joy from the Royal College of Midwives in the UK, and we've been working alongside the Bangladesh Midwifery Society. My microphone is up there. We've been working alongside the Bangladesh Midwifery Society for the past 5 years. Sangeeta is secretary of the Bangladesh Midwifery Society, and she was coordinating a program last year with funding from SET to help address, to help midwives who have provision of menstrual regulation, post-abortion care, and family planning in their scope of practice in Bangladesh, but most of them do not practice those skills because the environment does not enable them to do that. And so the program that we had together as a partnership, which Sangeeta was coordinating during COVID-19, was to address some of those barriers, identifying them through audit, and then we ran an alongside leadership development program for 26 young midwife leaders to give them the confidence and the skills to be able to negotiate with the health system managers locally to address some of those barriers. We worked with IPAS, which is an NGO that specializes in this kind of training, to provide that training locally. It was all online because at that time it was during the pandemic and travel was restricted. But it was a really successful program. And the point of it was to reduce, as well as to increase access to SRH services, to reduce transmission of COVID-19, because women didn't have to travel to the tertiary centres to be able to access those services, but could get them from a midwife locally in their Upazila Health Complex or health facility in Bangladesh. So it was really successful in those 5 centres. And Sangeeta is now, has won a fellowship for the Nursing Now Nursing Now Leadership Challenge Fellowship. She's one of the fellows, and she's implementing a quality improvement project as part of that fellowship to scale up that project to more health facilities. And so we're incredibly proud of her, and she's done an amazing job, and huge congratulations to the Bangladesh Midwifery Society for the amount of work that they're doing in raising the profile of midwives, especially in the area of SRH, but also across the board. So I just wanted to give my love and congratulations to all of the midwives on this call from Bangladesh, and to all midwives everywhere. Thank you.
Thank you so much, Joy. Thank you. I've heard about the partnership, and I've heard that it's been really great for Bangladesh Midwifery Society. And, you know, speaking to a lot of people from BMS, I know that the work that they do has been wonderful. But I think it's specifically in these times, it's really great to see that they're being able to do so much menstrual regulation and PAC work, because it's just, and I know living in Pakistan, I know what the contextual barriers can be to doing post-abortion care work. And I think a skilled midwife specifically who are able to access women in communities and at like primary care facilities could really change the landscape in this situation. Thank you so much. And I think Marine has a hand up. Marine, did you want to comment?
Yeah, absolutely. So I think a lot of what Joy was saying was really resonating with the kind of work that we're doing here. And I think when we talk about like an enabling environment, there's so many aspects that are important that we need to look at when we're sort of not only looking at improving the skill set of midwives, but also to enable them to practice better. So, you know, something as may seemingly be maybe very simple, but in Pakistan, there's a lot of duplication of reporting, whether it's paper-based or digital. It takes a lot of their time. And you think about, it's frustrating when you're sitting in a primary healthcare facility and watching them pen down duplicative feedback, because you're like, there needs to be a policy push from the top to just integrate everything. So we do have obviously provincial differences and disparities that exist on that. But a seemingly minor thing that has huge implications in healthcare delivery and access. So, you know, and I've seen this in the practice we do. For example, we give them checklists on how to, you know, use an IUD or how to counsel. But the patient turnover is so high, they can't use those checklists. It has to be more sharp. It has to be more innovative. It has to be more verbal. So when we talk about enabling factors, we're also looking at what specifically you are providing to midwives, to skilled birth attendants, that they're able to not only improve the quality of the services, but also they're able to enhance access. And that also comes from the kind of patient care that they give. Because if they do not counsel a patient, they do not prepare a patient, let's say for postpartum family planning or for post-abortion care or for, let's say, postnatal care, you will not see patients coming back. And in these communities, especially where we work, you know, your patient leaves with the baby and that's it. You never hear from them again unless something happens. So these enabling factors are multifaceted. They go from the policy perspective with political will down to the community level. So I just thought it'd probably be a little bit useful to highlight, because these are some of the things that I see in my work daily.
That's really useful. And that's absolutely true, because it's not just as simple as just, having a package and implementing it. There's so many other factors at play, and that's really like useful to hear as well. So I think this has just been a really fantastic panel. I've really enjoyed. I think everyone here has really enjoyed hearing from all of you. So thank you, Paridi, Tamim, Kola, Marine, and everyone else who contributed and has been here. And it's just been so great to see the kind of contributions that are being made in midwifery in this region. And I'm sure as I continue my stakeholder mapping, I learn so much more about all the exciting work that's being done. But this panel really helped us exemplify why midwives as primary health practitioners are just such a sustainable solution to strengthening health systems. So we know that, now that if midwives are supported globally through their life-saving work, they will be able to significantly improve health outcomes for people. And there's so many deaths that they'll be averting. Around 4.3 million deaths is the estimate. But however, the situation we're seeing with midwives is quite dismal. They're undervalued, they're underpaid, they're disrespected where they work in challenging work environments. And this means, I think the biggest issue is that this means they can't reach their potential and provide the transformational life-saving care that they should be providing. So we saw through the work of our speakers from Bangladesh, Pakistan, India, that the link between midwifery, maternal health, gender, and public health indicators are so clear. We can see the contribution that they can have to safe abortions. We can see that they can limit family sizes. They can just, through health education, antenatal care, they can bring women to facilities, or midwives can just do safe births. And it's just the interventions and the impact they can have is just so great. But they need the kind of support. They need support, and this ranges from training interventions, leadership program, more resources, better salaries, better support, and professional community building. And we need to and above all, I think we need to change how people understand the work and impact of midwives. So through the PUSH campaign, we aim to work on the barriers identified by campaigning on all of these issues. That's increased funding, improved training and education, better pay and working conditions, and increased status, respect, and autonomy. And as a closing, I'd just like to say that if we have any stakeholders in the audience today who would like to connect with, who are from the region, from Southeast Asia, South Asia, or are connected to the region in any way, and they'd like to share their midwifery work or their advocacy asks, or have ideas for us on ways that we can collaborate in these countries, my email will also be in the chat box. So please, if you can drop us an email, Leanne shared the other ways that you can connect, but you can also connect directly with me, and we can find ways to work together. So thank you, everyone. I think we'll be going back to the plenary now, and thank you so much for being here. This was a really great session.